Welcome back to the deep dive. Today we're really tackling a huge conceptual shift. We are moving far beyond, the conventional understanding of routine wound management.
Hmm.
We're diving into a whole new conceptual framework, one that's designed not just to manage complex wounds, but to actively, truly facilitate their complete healing.
Right.
And the material we've gathered introduces this really comprehensive paradigm. It's called wound balance.
That's right. And our mission today really is to unpack the sources that break down this holistic approach. Wound balance is, well, formally it's a care management conceptual framework.
Okay.
And what it does is it successfully merges the hard science of wound healing. I mean,
Yeah.
the detailed physiology, the cellular biology, with all those incredibly complex external factors.
Things outside the wound itself.
Exactly. The patient's own comorbidities, their social landscape, and even the bureaucratic and administrative limits that so often undermine successful outcomes in the real world.
So it's about achieving a state of equilibrium or homeostasis, not just at the wound site, but for the entire patient who is, trying to support that repair effort.
Yes.
And for you listening, what we're doing here is providing a shortcut to understanding how dysregulation in any of those areas, cellular, social, administrative, how it all contributes to poor healing.
And this is the key. Often before those poor outcomes are even visible or measurable by the traditional methods.
Right.
And we really have to emphasize the scope here. This is not just a guide for picking the right dressing. It's not that simple.
No.
This philosophy, it demands that clinicians address all the interconnecting issues whose dysregulation contributes to poor outcomes.
Yeah.
And they have to do it proactively.
Proactively, before the signs of chronicity even appear.
Before they even set in. It's a completely preventative mindset.
And that proactive versus reactive distinction, that seems to be the critical engine driving this whole framework.
It is.
Traditionally, complex wound care, it often waited, right? It waited until a wound met this very conservative definition of chronicity.
It did. And our sources define that pretty clearly. Chronicity is just a lack of or a less than expected decrease in wound measurements over a period of 4 to 12 weeks.
4 to 12 weeks. When you say it like that, it sounds like a lifetime in terms of healing.
Well, think about what that means. You're waiting a month, maybe 3 months, to confirm a wound is chronic. By then, you've already accumulated so much complexity, so much cellular dysfunction, and critically, you've lost these crucial windows for rapid healing.
So wound balance flips that entirely.
Completely. The whole premise is to identify and mitigate all the known barriers associated with delayed healing before you ever get to that clinical observation of chronicity.
So this is a transition from, say, reactively treating symptoms like visible infection or a lot of drainage to proactively treating each of what our sources call the patient's biomes.
The biomes, yes. To optimize the whole healing process from day one. And when you look at the known factors for delayed healing, the list is huge. It's so much more than just bacteria or moisture.
Right. The documents have this comprehensive table.
They do. And it includes intrinsic physiological issues like persistent inflammation and biofilm formation. And then it adds the systemic concerns, nutritional deficiencies, comorbid disease control.
And then it goes even wider.
Oh, absolutely.
Yeah.
It folds in the significant structural issues like social determinants of health and just a person's overall lifestyle. To get that balance, you have to address the whole system all at once.
The reality then is that as patients get older or they accumulate chronic illnesses, they just inherently face these barriers to healing.
They do. And Wound Balance acknowledges that. It says, look, while some patients might eventually heal despite these challenges, the best practice, the most ethical, the most efficient practice is to address these known barriers early.
To optimize the process.
Exactly. To prevent those really severe, long-term, poor outcomes, the severe pain, the debilitating infections, or just that drastically decreased quality of life.
Okay, let's start where the rubber meets the road then. The immediate clinical area, the wound environment itself. To achieve this optimal balance, the foundational principle here seems to be rigorous wound bed preparation, WBP.
WBP is absolutely the indispensable first step. And to get that wound environment balanced, you have to carefully consider what stage of healing the wound is in.
Because it's a sequence.
It's a sequence.
Yeah.
You have hemostasis, then inflammation, proliferation, and finally remodeling. Your WBP strategy has to be tailored to support the wound's progression through those stages, and you have to do it while you're anticipating all those external barriers.
So what's the core rule for the agents you use in WBP?
The philosophy is very clear on this. It insists on components that are both non-cytotoxic and prophylactic,
Okay, let's break this down. Non-cytotoxic
safe for human tissue. It won't harm the very cells that are trying to do the healing.
and prophylactic.
It means you apply them before you see the visible red flags of chronicity. You're acting as a prevention strategy, not a rescue mission.
So WBP isn't just one thing. It sounds like a complex, multimodal strategy.
It is. It's an approach where you never use a single modality in isolation. Multimodal wound management often includes specific anti-inflammation strategies, critical biofilm-based treatment, and really sophisticated moisture management.
But it's also about the root cause.
You have to look at the wound's etiology. For example, WBP for a venous ulcer is, well, it's just incomplete without mandatory compression to manage the edema.
And for diabetic foot ulcer.
It's non-existent without mandatory mechanical offloading. All the elements have to work together in concert.
Okay, let's unpack one of the most basic actions then. Cleansing. Our documents detail this very specific balance that has to be struck between safety and efficacy. It seems like a delicate trade-off.
It's absolutely a delicate trade-off. The clinical aim is, well, it's sensitive yet thorough. You're striking a balance between robustly reducing the harmful bioburden, dirt, debris,
Pathogen stuff.
all the bad stuff, while at the same time avoiding any disturbance or harm to the fragile healing tissues, the human cells, the enzymes, the molecules that are necessary for repair. You can't harm your own team.
And I found it really powerful that the source material brings in this, foundational principle of toxicology here. From Paracelsus, the dose makes the poison.
That principle, it just perfectly encapsulates the nuance you need in modern wound care. What it means is a substance can only be harmful or toxic if it reaches a susceptible system in a high enough concentration.
So it's not that the substance itself is inherently bad.
Yes, exactly. Take common antimicrobials in wound dressings. They could, in theory, be cytotoxic if you just poured them on at high concentrations. But modern dressings, they keep the concentration within a therapeutic window.
So it's effective against bacteria.
But it's not harming the human fibroblasts or keratinocytes. So the clinician's job, informed by wound balance, is to always choose the safest, most efficacious option, understanding that safety is all about the dose.
Okay, so given that critical safety constraint, what agents are typically preferred for this delicate balance?
Well, surfactants, which are essentially just specialized soap-like molecules, are used very frequently because they have excellent safety and efficacy profiles.
How do they work?
They reduce surface tension, and that allows them to effectively penetrate, lift, and suspend necrotic tissue and debris from the complex surfaces of the wound bed, but without any chemical aggression.
So you get great results from combining things.
Yes. The superior and safest cleansing results often come from using a combination of a non-cytotoxic antimicrobial along with a surfactant-based cleansing agent. That way you handle both the visible debris and the microscopic bioburden.
That sounds simple enough, but the procedure detail here is crucial. It's not just a quick squirt and a dab.
No, absolutely not. The technique is just as important as the agent. For extremity ulcers, the recommendation is rigorous. Clinicians need to wash the wound, the periwound skin, that's the area right around the wound, and often the entire distal extremity.
Applying some pressure, too.
Applying moderate pressure, as tolerated by the patient, of course. This methodical approach ensures you get a comprehensive reduction of bioburden throughout the whole region, which prevents migration and contamination back to that fragile healing site.
Okay, so moving from chemical intervention to physical removal. Debridement is still a core standard of care for appropriate complex wounds,
It is.
meaning those without advanced ischemia or uncontrolled inflammatory issues.
Yes. Debridement is a direct intervention that immediately restores balance.
Yeah.
You're physically removing necrotic tissue, which is just non-living material that serves no healing function.
And by removing it,
You minimize the release of harmful proteolytic enzymes, you decrease the bacterial bioburden directly, and fundamentally you facilitate healing by creating a favorable surface for granulation tissue to form and for the epithelial edge to migrate across.
and this is where we get into the really fascinating cellular biology, the deep dive into biofilm. What exactly is this chronic microbial presence doing that stops healing in its tracks?
Biofilm is the absolute critical villain in chronic wounds. It's not just, free-floating bacteria. It's a structured, complex community of microorganisms.
And they build a shield.
They're encased in a self-produced protective matrix. This sort of slimy matrix makes the bacteria up to 1,000 times more resistant to antibiotics and to the body's own immune response.
1,000 times.
Wow. So this chronic bacterial load, it severely damages the surrounding tissue, and it necessitates clinical intervention. Even if you don't see overt symptoms of a systemic infection yet, when you debride, you are physically ripping off that resilient biofilm shield, which then allows the healing cascade to restart.
And there's another specific, very technical benefit of sharp debridement that directly impacts cellular aging, this idea of removing the SSP phenotype. We have to go into this because this is where the science gets really cool. Why is removing these senescent cells so critical?
This is truly foundational to chronic wound biology. Senescent cells are cells that have basically reached the end of their life. They've stopped dividing.
But they're not dead.
They are not dead. Crucially, they are still metabolically active. They adopt a condition called the senescence-associated secretory phenotype, or SASP.
SAS, okay.
And what this means is they are constantly releasing this potent mix of pro-inflammatory factors, molecules like interleukin-6, interleukin-8, and excessive growth factors.
So they're not just stagnant cells hanging around. They are actively poisoning the healing environment.
Precisely. They're actively driving dysfunctional inflammation. And what's worse is that these SAP molecules they release, they can induce senescence in the neighboring healthy cells.
Oh no, so it spreads.
It creates a self-perpetuating positive feedback loop, a vicious cycle that keeps the wound trapped permanently in the inflammatory stage, which prevents it from ever moving on to proliferation and remodeling.
So a correctly performed sharp debridement.
It physically cuts out these senescent cells, it breaks that SAP feedback loop, and it finally allows the tissue to progress toward closure.
So even a foundational practice like debridement has to incorporate the entire wound balance philosophy. It is not just about removing dead tissue, it's about disrupting a cellular aging cycle.
Exactly. And wound balance during debridement, it mandates person-centered care. The practitioner has to consider the patient's preferences, their pain tolerance, their specific physiological state like, do they have advanced arterial disease? And they have to use that information when choosing the type and extent of debridement. The method has to be acceptable, appropriate, and aligned with the patient's overall goals and their physiological status.
Okay, Section 2 moves us into managing the physical microenvironment of the wound. Let's start with the critical issue of exudate management. The material identifies poor exudate management as a huge barrier to healing.
It's a profound disruptor, both chemically and physically. Poor exudate management, it potentiates the dysfunctional inflammation that just characterizes these slow-healing, stalled wounds.
And
Physically, if the periwound tissue is poorly managed, if it's constantly wet, it prevents effective epithelial edge migration. It essentially macerates the healthy skin and just halts any progress toward closure. And chemically, it assists in the formation and growth of heavy bacterial loads and biofilm.
let's delve deeper into the chemical content of that drainage. Why is the exudate in a stalled wound so harmful?
The fluid in a chronic wound is fundamentally different from the clear, transient fluid you see in acute healing. The exudate in a stalled wound is inflammatory drainage. It contains high concentrations of proteases, cytokines, and critically, matrix metalloproteinases.
MMPs.
MMPs are enzymes, right? What's their normal job and why are they so harmful here?
They're absolutely crucial enzymes for normal tissue breakdown and remodeling. They're like the body's internal demolition crew. They degrade the extracellular matrix, the collagen and elastin to allow cells to move and new tissue to form.
So they're good, normally. But in chronic stalled wounds, these enzymes become overexpressed and dysregulated. They're produced excessively by neutrophils and macrophages that are perpetually stuck in that inflammatory state.
So you get a net loss of structure.
A net loss of collagen and matrix structure. The wound is literally being dismantled faster than the fibroblasts can build new tissue. It traps the wound in stasis.
And that explains why just using traditional dry methods is so detrimental.
Precisely. Gauze dressings or abdominal pads are actively discouraged because they offer no mechanism to sequester or neutralize this damaging inflammatory exudate. They just hold that chemical soup right in contact with the fragile wound bed.
So the only appropriate strategy is to use advanced modalities.
The only way is to use advanced wound care modalities that are specifically designed to manage the fluid dynamics and the chemical content.
Which brings us to the advanced approach, undisturbed moist wound healing, or MWH. Our sources position this as the recommended treatment for all non-palliative wounds, a priority intervention.
MWH creates the optimal undisturbed environment. The benefits of advanced wound dressings are extensive. They absorb, they sequester, they retain, and they actively remove those damaging wound inhibitors and microorganisms away from the tissue.
And beyond that?
Beyond that, they minimize contamination from the outside, they prevent secondary infection, minimize scarring, and, this is a big one for the patient, they significantly decrease pain by protecting exposed nerve endings.
And here's the surprising factor for me, the thermal factor. The material highlights that the cost of frequent dressing changes goes way beyond just materials and time. It's physiological.
It is a stunning realization when you first encounter it. Local hypothermia occurs with frequent dressing changes, even just temporarily removing the dressing.
Just taking it off for a minute.
Just a minute. This cooling effect, even a drop of a few degrees Celsius, it negatively affects the crucial chemical processes involved in healing, especially the function of enzymes and the production and use of growth factors.
So every time a nurse removes a dressing unnecessarily, they're literally disrupting the chemical factory of the body.
Exactly. And furthermore, local cooling triggers vasoconstriction. That reduces blood flow and, critically, oxygen delivery to the wound bed. This hypoxia then impairs the migration, the adherence, and the phagocytosis action of leukocytes,
The immune cells.
the very immune cells you need to fight off infection. And fibroblasts, the cells responsible for repair, they're documented to show dysfunctional healing during local hypothermia. So limiting the frequency of changes is non-negotiable for maintaining normothermia and allowing the body to sustain its healing efforts without constant thermal disruption.
That makes the comparison between traditional methods and advanced dressings even more stark.
It really highlights the functional inadequacy of something like gauze. Gauze fails to protect from contamination. It contributes directly to inflammation because it can't sequester that drainage, and because it saturates so quickly, it has to be changed daily.
Which leads to the very cycle you're trying to avoid.
It necessitates the disturbed healing cycle and the local hypothermia we want to avoid. Advanced dressings, by maintaining that stable thermal and moisture environment, are just superior. And they can even provide protective benefits like offloading and shear absorption over bony prominences.
To put a visual cue on all of this clinical activity, let's talk about how the visible tissue quality signals healing progression. The sources provide clear, distinct descriptions of healthy versus unhealthy granulation tissue. These are essential feedback loops.
Tissue quality is the clinician's immediate feedback. Healthy tissue, which would correspond to figure 1 in the sources, should be described as beefy and bright red.
Beefy and red.
Right. That indicates excellent vascularization and oxygen delivery. It should have a desirable texture, described as cobblestoning or having granules, which signals active, organized formation of new matrix.
And what if the tissue looks, say, smooth or just kind of pink?
If the tissue is poor or unhealthy, described as having a smooth texture and a pale pink coloration, like in Figure 2, that suggests significant underlying challenges.
It's a warning sign.
It's a huge warning sign. That poor quality signals that microenvironment factors, maybe an undetected biofilm, unresolved chronic exudate, or mild hypoxemia, are actively challenging the healing process and require immediate focused intervention.
And then there's the presentation that hints at deeper, more systemic, patient-related issues, things beyond the local wound bed.
That would be hypergranulation, which corresponds to Figure 3. This tissue often presents as large, fragile lobes that bleed easily. They're friable, and they have a deep burgundy coloration.
So it looks like growth, but it's bad growth.
It's disorganized, and it often impedes epithelial migration. When tissue displays this intense, disorganized, or redundant growth, it is a strong indication that systemic, patient-related factors like uncontrolled comorbidities, significant nutritional deficiencies, or high mechanical stress need urgent consideration and adjustment.
Okay, that need for proactive intervention is really underscored by this next concept, the red flags of chronicity. These seem to be early warning systems telling the clinician that a complex wound is probably not going to heal promptly, even if it hasn't officially met that definition of chronicity yet.
These red flags are crucial risk factors for delayed healing. They include the poor granulation tissue quality we just talked about, along with other symptoms of, heavy bioburden and stalled progress.
Like what?
Things like subtle periwand edema or swelling, increased and usually tan or pale drainage, the presence of any necrotic tissue slew or eschar, and surrounding dermatitis or inflammation.
So if the whole philosophy of wound balance is prevention, how are these red flags used?
Well, the ideal scenario is that proactive, evidence-based WBP prevents these flags from ever showing up at all.
But if they do?
But if they do appear, even when you think you're doing appropriate wound bed prep, they are a powerful signal. They signal the need for a much deeper investigation.
What kind of investigation?
They might signal the need for a biopsy to rule out malignancy, immediate treatment for suspected cellulitis, or, most commonly, a rigorous investigation into or undertreated systemic patient factors that are stalling the process from the inside out.
And to help providers do that investigation systematically, the sources introduced the Biomes tool. This seems like a really practical, structured tool for early problem identification, especially in non-specialized settings.
Oh, Biomes is an excellent structured approach for systematic risk assessment. Make sure that the assessment covers clinical, metabolic, and social risks all at once, right from the very start.
Which is vital for, say, an urgent care or ER doc.
Exactly. Because frontline providers often lack the deep specialization of a dedicated wound center. So this structured tool forces them to look beyond just the visible hole in the patient's skin.
Let's break down the acronym then, and the risk scoring.
Certainly, Biomes ensures that 6 categories are assessed. B is for blood flow. Blood flow is circulation adequate. This requires objective testing, like checking pedal pulses or getting an ankle brachial index.
To rule out ischemia.
To rule out ischemia, which fundamentally prevents healing. Then I is for infection control. Is bioburden a clinical or visual issue?
So you're looking for pain, redness, odor.
Exactly. Even if overt sepsis isn't present, O is for offloading. Is there unrelieved pressure or excessive shear stress on the wound? For any wound on a weight-bearing surface, this is an immediate critical barrier.
And the metabolic.
Metabolic and comorbidities. Are diseases like diabetes or kidney failure controlled? Is the patient severely malnourished?
G is for exudate.
Exudate, moisture, and bioburden. That microenvironment balanced. Are we managing the fluid and the chemical inhibitors, the MMPs we talked about?
And then S, the big one.
S is for social and economic barriers. Are external factors like housing instability, transportation issues, or just a lack of resources limiting their ability to stick with the care plan?
That S is really what separates this from a purely clinical tool.
It is. And the risk assignment is designed to trigger immediate action. You assign 1 point for each barrier that could affect healing. A patient with 1 biomes is moderate risk.
And 2 or more.
A patient with 2 or more biomes is immediately considered high risk. The implication is unambiguous. Moderate or high-risk patients should be referred to a wound care specialist immediately for early and aggressive medical management.
Instead of just waiting and watching in primary care.
Right. Early intervention, guided by biomes, prevents weeks or months of stalled healing.
This all really stresses that clinical expertise alone is not enough if the patient isn't invested or able to participate. This moves us to the crucial concept of patient balance, starting with quality of life, QOL.
Right. QOL is defined simply as how a patient feels about the overall impact of their medical conditions and the treatments on their daily life. And we have to recognize that complex wounds rarely happen in a vacuum.
No, they're usually in patients with a lot of other problems.
Exactly. They're typically found in patients with multiple comorbid diseases that profoundly affect their mobility, increase pain, drive depression, and cause significant social distress, all of which leads to a significantly lower QOL.
So we're looking at a bidirectional relationship here. It's not just that the wound makes life bad, but a bad life can make the wound worse.
That bidirectional relationship is absolutely key. The underlying conditions, the chronic pain, the depression, the poor mobility, they aren't just a consequence of the wound. They contribute to the physiological conditions that cause the wound in the first place.
And they directly impact the body's ability to heal.
Directly. Chronic stress and depression, for example, suppress the immune system. They lead to elevated cortisol levels, which are known to inhibit fibroblast function and collagen deposition. So if a patient is unable or unwilling to adhere to a care plan because of overwhelming pain or distress, the most advanced cellular science in the world becomes irrelevant.
Which means you have to have shared decision-making. Clinicians have to balance the need for intense, potentially disruptive interventions with the patient's personal quality of life needs.
Precisely. Wound balance requires person-centered care. Adopting this approach ensures that recommended interventions are practical and likely to be followed, which just drastically improves adherence.
It's about fitting the plan to the person.
It is. Clinicians have to identify individual needs, whether it's childcare, transportation, dietary restrictions, to guarantee the recommended plan fits within the patient's existing life and their stated healing goals. And this is not a conversation for a rushed 10-minute visit. It requires time, emotional intelligence, and seamless teamwork.
It sounds like the primary goal of this constant communication is to maintain the patient's internal locus of control.
That is the psychological driver of success.
Hmm.
The patient needs to feel like an active participant, not just a passive recipient of orders.
Mm-hmm.
Their individual needs, their preferences, their lifestyle, it all has to be continually solicited at every key strategy point. Selecting the site of care, choosing offloading devices, selecting a dressing, and this review has to happen at every single visit.
And since life is complex, the interventions you offer have to be flexible.
They have to be. The plan has to exist on a flexible spectrum. It has to be contingent on patient-centered variables like cost, comfort, time commitment, social aspects. It has to be titrated, as tolerated, and as accessible, progressing only as the patient's own change readiness evolves.
Because if you force a plan they can't maintain.
You guarantee non-adherence and failure.
Our sources had an interesting, almost self-critical note here, acknowledging a struggle for providers in this area.
Yes. The source material observes that healthcare providers and researchers sometimes struggle to understand why individuals might display what they perceive as a limited value of their lives or demonstrate irrationality in their choices.
Like consistently choosing to smoke over having better circulation.
Exactly. And this really highlights the gap between the clinical ideal and the patient's reality. It points directly back to the need for emotional intelligence and recognizing that the patient's reality, which includes deep-seated social and economic barriers, is often the definitive factor, not the clinician's ideal treatment protocol.
And that takes us out of the clinical room entirely and into the sphere of care balance, which addresses these huge structural and systemic issues. We have to start with the massive hurdle of the social determinants of health, or SDOH.
This is truly the grand challenge of 21st century healthcare. We've reached a consensus that factors other than the specific healthcare patients receive are driving their outcomes.
Right, SDOH are the structural drivers.
They are. The things affecting outcomes beyond the clinical, walls housing, income, community safety. Even if a provider delivers completely equitable, evidence-based clinical care to every single patient, perfectly, the outcomes will still be variable because of the environment and social conditions those patients live in.
And the crucial statistic here is what makes this topic non-negotiable for a deep dive like ours.
It is the headline figure. Social determinants of health determine up to 80% of health outcomes.
80%.
80%,
Right.
which means focusing only on the physiological processes of the wound bed, no matter how advanced, is addressing only a fraction, the visible 20%, of the total problem.
So disparities in SDOH, bias, chronic stress.
All of it. Generational traumas. They lead directly to clinically relevant alterations in both wound occurrence and in successful wound healing.
Can we be specific? How does lacking housing or transportation directly compromise the healing of, say, a leg ulcer?
Okay, let's use concrete examples. If a patient is homeless, they can't keep their compression bandaging clean or dry. That just accelerates their infection risk.
Mm-hmm.
If they live in a food desert, they can't access the high-protein diet they need to rebuild tissue. That leads directly to the nutritional deficiencies we listed under the M in biomes.
And transportation.
If they lack reliable transportation, they miss crucial follow-up appointments. They miss the appointments needed to change advanced time-sensitive dressings, or worse, they miss their sharp debridement sessions. And that allows the SAP phenotype and the biofilm to reestablish themselves, which directly undermines all the expensive clinical work that's been done.
So for the wound balance philosophy to truly achieve health equity, we need these structural drivers of health.
Absolutely. Creating a culture of health that prevents illness and promotes healing requires structural support. Safe staffing levels, guaranteed housing, reliable food sources, education, and comprehensive health care access, which has to include mental health care.
It's everyone's job.
Everyone. From researchers gathering culturally competent data to administrators allocating resources for transportation, everyone has a critical role in increasing health equity.
Now let's talk about the internal organizational barriers. Starting with administrative harms, or AH. This is what happens when the system itself hurts the people who are trying to fix the problems.
Administrative harms are defined as the adverse consequences of administrative decisions within healthcare. So organizational pressures, burdensome documentation requirements, toxic workplace cultures, as experienced by the clinicians and leaders on the front lines.
And these harms contribute to burnout.
They contribute significantly to clinician moral injury and burnout.
And how do these administrative harms then potentiate barriers to equitable patient outcomes? Let's trace that direct link from burnout to poor healing.
Okay, the link is adherence and time. Providing wound balance care is time-intensive. It requires detailed documentation, prior authorizations for supplies, and most importantly, the time for that emotional intelligence and shared decision-making with the patient.
And when clinicians are burned out?
When they're morally injured or burned out because of excessive administrative demands and productivity pressures, they have to cut corners. They reduce the time they spend on patient education. They skip the deep dive into social barriers, the S in biomes, and they're just less able to facilitate that flexible, patient-driven care that's necessary for true adherence. Administrative harm directly breaches the person-centered care mandate.
Another organizational problem that was highlighted is the lack of standardized practice among wound clinicians.
This is a complex reality. The diverse educational backgrounds and experiences that many wound clinicians bring to the specialty are necessary, to meet the high prevalence of patients with wounds.
But that diversity can be a problem.
It can unintentionally contribute to the perpetuation of traditional, non-evidence-based practices, the very ritualistic, disruptive practices the wound balance philosophy is trying to replace.
So standardization is key.
Standardization, through rigorous education and established protocols, is needed to ensure evidence-based care is consistently applied, and that every patient, regardless of where they enter the system, gets the same high quality of care.
And finally, the massive barrier of policy and reimbursement structures. Our sources have a powerful critique of the current fee-for-service model.
The fee-for-service, or FFS model, is fundamentally flawed for complex care like wound balance. It compensates providers based on the volume of services they deliver, not the value or efficiency of the outcome.
So it fails to incentivize the proactive practices that would actually speed up healing.
It directly fails to promote them.
Wait, if the fee-for-service model rewards volume, doesn't that actually encourage things like frequent debridements and daily dressing changes? How is this philosophy financially sustainable if the goal is to heal faster?
That is the essential contradiction. FFS incentivizes activity. Many visits, many procedures, many inexpensive dressings. It does not incentivize the outcome, which would be rapid, successful closure through preventative measures and expensive advanced long-wear dressings.
So it rewards managing, not healing.
Exactly. For instance, wound balance demands you optimize the wound bed and modify patient factors early on. That requires an upfront investment in time and expensive materials. FFS often doesn't adequately reward that initial investment, so it keeps the system trapped in this cycle of managing rather than healing.
And this structural flaw feeds directly into the access barrier.
Absolutely. The result is insurance-driven limitations that restrict patient access to the very advanced dressings and therapies that are proven to enhance healing.
So even if the doctor knows what's best.
If the physician knows an advanced dressing is superior for undisturbed moist wound healing, but the patient's insurance won't cover it, they are often forced back into suboptimal, disruptive practices like daily gauze changes. And that undermines the entire concept of wound balance, and it increases the overall duration and cost of care in the long run.
So to consolidate all of these structural issues, let's quickly summarize the diverse barriers to transformation that have to be overcome for wound balance to really be successful.
We can categorize these systemic failures. First is access and logistics. This includes limited access to specialized wound centers and advanced therapies, coupled with logistical hurdles like transportation issues that prevent consistent attendance.
Okay.
Then there are resource deficits, the persistent lack of necessary supplies, appropriate equipment like specialized offloading boots or community resources to support optimal healing at home.
And finally, adherence.
Adherence challenges. This is the systemic failure to address the S in biomes. It results in the patient's inability or unwillingness to adhere to key elements of the care plan, often because of their social or economic realities.
These barriers really just confirm that healing a complex wound is a multi-system social and policy challenge. It is not just a localized physiological repair job. This has been an incredibly extensive deep dive into the philosophy of wound balance. It's taken us from the microscopic action of senescent cells all the way to the massive impact of systemic policy failure. So to wrap up, let's synthesize the core merger that this framework represents.
I think at its heart, wound balance successfully merges rigorous, evidence-based wound bed preparation and targeted treatment with the critical acknowledgement of all the social and administrative considerations that inevitably complicate care.
So we're moving away from the defeatist language.
We're moving away from the pitfalls of chronic wounds and managing them through ritualistic practices and moving toward a proactive wound healing mindset.
And that shift demands a goal-directed approach,
Yeah.
one that addresses those modifiable risk factors associated with dysfunctional wound environments, recognizing that the dysregulation happens both inside and outside the patient's body.
Right.
We've talked about the damaging effects of thermal disruption, the insidious nature of that SAP phenotype feedback loop, and that staggering statistic that social factors drive 80% of our outcomes.
The end goal here is truly transformative. It's to expedite healing, to limit the profound psychosocial stress, the chronic pain, and the decreased quality of life that complex wounds inflict on people.
And this is achieved by delivering more equitable, multifaceted care.
Exactly. Care that acknowledges that the molecular, the cellular, the social, and the environmental environments are all contributing factors to successful outcomes. It's about fundamentally improving global wound care standards.
We've established that the ultimate aspiration here is improved outcomes across entire populations by addressing the current gaps in care and transforming how we approach wound healing worldwide.
Absolutely. And as we conclude, I want to leave you, the listener, with a final provocative thought built directly in the material we just covered.
Okay.
We noted that social determinants of health drive 80% of outcomes, and that administrative harms frequently limit clinician effectiveness, contributing to burnout and reducing the quality of person-centered care. So if you are not a clinician, if you're an administrator, a policy advocate, or you work in community resources, how can you best advocate for the full implementation of the wound balance concept within your organizational or community structure to directly address those non-physiological drivers of disparities, ensuring that the clinical advances we discussed today can actually reach every patient who needs them? That, I think, is the next frontier of equitable health.